Hello and welcome to Healthy Veins, Healthy Legs, the only radio program that will give you a leg up on ways to identify and get help for ailments of the leg that can not only be cosmetically bothersome, but could actually be a big threat to your overall health and well-being. Now, here's your host, Mike Buck, and Hawaii's senior vein specialist and vascular surgeon, Dr. Robert Kistner.
Welcome, one and all. You know, every now and again when I hear the opening of that show, I think, oh my goodness, we're putting people in an ambulance. And that's not it at all. We're here to talk about your legs and your veins in your legs. And today we have an opportunity to talk about something that comes up all the time as one of the symptoms of the possible vein disease or varicose vein disease. And when Dr. Kistner sent me a list of some of the things that we're going to talk about today, I thought, wow, this is terrific. Because how many people right now listening to the program, and I'm talking to you out there, have had at one time or another a swole up leg, you know, and what do you think it is, and what do you think it is right now? Maybe your leg's just swollen today, and you don't know what's going on. And I guess, Dr. Kistner, that you said off the air, and I guess this is one of the primary reasons people will come to see a specialist, because their leg's swollen up, and they don't remember getting the sting, and they don't remember banging it. They just got a swollen leg.
You know, that's right, Mike. In the past couple of weeks, it's been like a deluge in my office of people with swollen red legs at the lower end of their body, and really it's a miserable symptom. It's a discomfort, and it's a recurrent thing. And they go to see their doctors, and often these are kind of frightening-looking things. They might go on antibiotics, they might go on water pills, they might get all kinds of tests for their hearts and kidneys and so forth. So it's highly practical.
You know, it occurs, a couple of things occur to me. And that is that, you know, whatever drives somebody to get attention, whatever is the signal, it's good that it motivated them. But I'm wondering, and I speak from personal experience, because as somebody that was formerly diagnosed as being morbidly obese, I had a lot of these kind of things happen, but always looked for some way to get around it. For instance, let me ask you this. Let's say that you've got type 2 diabetes, and you've been diagnosed and put on some sort of medication, whether it's Alderil or one of these things that you get, and then you have your blood sugar done, and it's 95, and you think perfect, but it really isn't, is it? It's 95 because you're taking a pill. If you weren't taking the pill, it might be up 150, 200, whatever. In other words, you've made the symptom go away, but you haven't made the disease go away.
Well, and so the reason for taking the pill is to control the effects of the high blood sugar that occurs with diabetes. And so effective levels of control, like a 95 or an A1C in the normal range, these would be an indication that you're on the proper therapeutic dose to limit the development of complications over time.
But what about this? What about people that think I'm not sick anymore? I don't have diabetes anymore. I got the pill.
Well, that's not fair.
No, really.
They still got the disease. They're like, treating it.
It's almost like when a person finally realizes that don't be vain, put on your glasses. In other words, you need.
I was going to say
you need glasses.
That's right.
But the glasses you are aware of every day when you pick them up, and when you don't have them, you need them. You go grab them. But if you take that pill every morning and you don't monitor your diet, you really haven't cured the disease.
So you're saying that taking the pill is like putting on your glasses. And, right. Well, absolutely. It's a true thing.
So it makes sense then. The older you get and the more things that you get going wrong with your body, all of a sudden you're taking a pill for this, you're taking a pill for that. You're a train wreck. You just haven't gone off the track yet. In other words, you're taking all of this stuff that masks the symptoms but don't cure the disease.
That's right, but they ideally what these things do is slow down the progression of the disease. So we're talking about disease. We kick that term around. So we're really talking about an affliction that goes on over time and can get worse over time. And so what you want to do is stop that progress.
Okay, what then would be for all of us that are out there suffering with a swollen leg or legs? Sometimes we know that from previous programs, and you can dive into that a little later. If it's just one leg, that's a clear signal that there's something serious going on. But just to give people sort of a ballpark idea, what are the main reasons? What are several of the main reasons why you get a swollen leg in the first place?
Okay. There are a lot of them. A lot of reasons. So it sounds like simple. Doc, I got a swollen leg. What's wrong with me? But it's a
no
very,
answer for that right off the bat,
no,
is there?
It's pretty complex for the doctor
yeah.
because he's got a lot of things to think about, or she. So, but what are they? So the biggest thing is whether the cause is central in the body, like your heart or your kidneys or your nutrition going wrong. Those can cause swelling in your legs, usually in both legs.
Mm-hmm.
Versus something that's locally in the leg that causes the leg to swell, and that would be things like an infection or an injury or venous disease with bad valves, or even a blood clot in your leg, or another whole category of things called lymphedema, and that's where the lymphatics, which drain the tissue water out of the legs, they get jammed up one way or another.
Okay, well that's 7 or 8 right off the top of the head.
Yeah, and that's only opening the door.
Yeah. Okay. Now, and that would indicate then that probably if they're just opening the door, or let's say we round the number off at an even 10.
Okay.
You got 10 reasons why your leg can get swollen up. It would certainly indicate that there isn't probably one treatment that's going to fix every swollen leg.
No, and some are ridiculously simple, and some are incredibly complex. And to name just, suppose you had maybe a little injury, mm-hmm. and the leg swelled up and it got red in some area, and you had some inflammation. Well, you counteract that or do whatever it needs to treat that, and it goes away. That's ridiculously simple. Suppose you're also I have a swollen leg, and both legs are swollen, and you weigh 422 pounds, and you're 5 feet 4 inches tall, and so you have morbid obesity, and maybe your heart isn't working too well, and on and on and on. So you can get into something where it would take a massive change in your body environment and habitus in order to affect it.
That sort of hit me as a funny bone, because whenever somebody hears a siren, you immediately become alert that there's a siren. Or when you're driving down the street and you see a blue light in the back, you look at your speedometer to make sure you're not speeding, because that's a cop. In some respects, aren't some of these symptoms a siren that we either we ignore and therefore increase the problem, or we react to? And in other words, is swelling a good thing sometimes?
Well, swelling is the body's reaction to something, mm-hmm. Maybe good or bad, but and it can be either one.
I'm thinking that if something doesn't get swollen, you may not even know you have a problem.
You don't even know the parts are. I mean, you don't know your leg's there until it hurts.
Well, one of the things that you've talked about before is, and when we talk about venous disease and things, is that quite often as we get older, particularly if we are in a job where we're standing up all the time, that you get heavy legs, you get tired legs, and you get, a fluid buildup in the legs. And usually you've said in the past that the best thing to do for that is right away is get off them, elevate them. Mm-hmm. How many people elevate a swollen leg thinking, well, that's all I got to do?
I don't know the answer to that. Maybe it's more than I would think. But I think the problem is that a lot of people try it, but it doesn't work because mm-hmm. they put the leg down and it still swells again, or
Sure.
even it stays swollen.
I would imagine, too, that the more a condition advances, the quicker it would swell up again after you got it from elevated. I do know that if you lie down to go to sleep and you have a whole evening or a whole night of nice rested sleep with your legs either elevated or certainly, prone, when you get up, if you have a real problem, they swell up immediately within a few minutes.
Well, we could just take that example that you said. You see a swollen leg in the afternoon, so you say, well, I'll go to bed and put the leg up.
Yeah, this will go away.
Well, that's a pretty good test, because if you get up the next day and your leg is normal, then you could rule out things like an infection or some important inflammatory problem in your leg, because it's not going to go away that fast.
Right. I got it.
But on the other hand, if it is all gone, then you can say, well, this isn't too serious, and go on. But you may be wrong in that after you've been up for a few hours, the swelling comes back. So that would be a recurrent condition. So
what I get concerned about is people, even like me, that get a swollen leg and there's more than one thing going on. In other words, a swollen leg, you could have 6 different afflictions in that leg. You could have trauma. You could have a gout. You could have a bad valve in your vein. You could have an infection. You could have a lot of things.
Right, and so the reason I thought this was a good subject to discuss was because so many people come in and they don't even know they have a swollen leg. They haven't looked at it, and you do have to look at it pretty carefully to tell. In fact, the doctor has to look at it very carefully to determine whether there's swelling or edema in the leg.
Don't you, though, sometimes when you get a new patient or somebody that you haven't seen for a while, isn't that something that you pick up on literally immediately when somebody is ready to be examined?
If you look at it.
Yeah, I mean, it's in other words,
sure.
For a professional like yourself, it's that visible immediately. You can say, wow, your left leg's all swollen up. Does it hurt?
Yeah, but that kind of depends on what kind of physician you are. So if people are going to their general doc and they're used to looking at maybe other things in the legs last of all, they might ignore it in a hurry, or you have another problem and they don't see it. So it's something that the patient really has to report to the doc.
Okay, now when you have different conditions, let's take the one that I'm the most familiar with: obesity. You're big everywhere. In other words, your hat size doesn't maybe go up to a 10, but everywhere else your arms are swollen, your chest, your tummy, your calves, your ankles, and pretty soon you think, well, I don't even have any ankles. I just go from leg to foot. There's no nice little shape there. That's because I guess you've literally filled up every cell you could. I mean, you're just bloated out. You're maxed out there.
Well, I don't know. Do you think the very obese person even looks at their lower legs?
Well, I can tell you one thing. A lot of very obese people can't see their feet.
That's what I'm saying. Yeah,
out of sight, out of mind, I guess. But yeah, I think that's a problem. And most people that are obese, and I can tell you guys and gals out there, if you answer yes to any of these questions, you might have a condition. Number one, do you shy away from being photographed? Okay.
Mm-hmm.
Why would you think that'd be a problem? Well, let's say that you and I get a picture taken together, and if you could see me and Doc right now, Doc's a regular-sized guy, and I'm kind of a big guy. But if you're a really, really big guy, the only time you really see that is if you see a picture of you and, quote, a normal person. And you may not even see that, but you will. And so you shy away from things like photographs.
You do.
And from things like beaches, and from things like ballroom dancing classes, and all of the things that you might want to do that you don't anymore because either you physically can't do it or you're worried about the way you look. And yeah.
Well, wait a minute. At that time, are you also saying to yourself somewhere inside, I'm overweight and I need to do something about it?
Yeah, but you know what I think a lot of people do? They'll make that statement of themselves and they'll go grab a sandwich.
Yeah, that makes them so nervous they need a sandwich.
That's the comfort zone,
Yeah, sure.
When people
are
morbidly obese, the happiest times are usually, I guess, when they're eating. I don't know if that was necessarily my case all the time. There's some physiological things that go on. For instance, and I learned this from my doctor, my internist a long time ago, that, you got to eat to maintain your body weight. The bigger you get, the more you got to eat. So after a while, you're eating all the time just to maintain that body weight. You may not even want to be, but something inside of you telling you eat because I need all of this stuff to keep going.
So there would be a reason that people could be big and have these red swollen legs in the bottom and not know it.
Yeah, sure.
Now, that's the thing I'm seeing in the office.
That's what you're asking me. And yes, and I'm thinking that maybe sometimes when you see somebody in the office, you're sharing something with them that may not even know about themselves.
Yeah. Often so frequently we're seeing people that have been referred by other physicians who have seen inflammation, and in fact many of them may be on like antibiotics and diuretics, water pills, and all kinds of medications for a number of reasons, some good and some not. But if they're on it just for that swelling and redness in the lower leg, it may be that's not the right treatment, that the right treatment is to get rid of the swelling.
Yeah, I mean, obviously, if the treatment is right and the swelling goes away in a relatively short period of time, it was the right diagnosis,
that's good.
The right treatment. But if it recurs, there's something going on. Let me ask you this, because you mentioned diuretics, and as a formerly morbidly obese person, one of the things that you suffer is edema, swelling, and usually sometimes you are prescribed a diuretic, and that is to help your body purge out the extra liquid. I do know, like any other drug, that there are cases where people really would abuse the diuretic to the point where they're taking so much they damage kidneys, maybe, or they damage the ability to normally eliminate the water. If you didn't take the pill, maybe you stop eliminating water.
Well, the other thing is you might excrete too much potassium, and
the
you get
electrolyte thing, right?
Electrolyte problem. Yeah. So there are certainly side effects that are undesirable, to say the least, and maybe dangerous to some degree.
Well, I guess if every affliction came when you were 25, that all your parts were working well except this one area where you need to get some attention. But when you become 50, or when you become 60 or 70, it's safe to assume that you're dragging a few suitcases with you. You got this little thing and that little thing. So here comes me to my doctor and my swollen leg. He gave me the stuff for a while, and finally one day he wakes up and says, "You know what? I think you better go see a specialist. Whatever we're doing here is not doing the trick. We're out of options. You got to go see. You got to go get further diagnosed."
Yeah, and I think there's painful swelling and painless swelling, and a lot of the physician will often say you have edema in your legs, and I don't know what that means to most people, but it probably sounds fairly benign. And yet that means there's retained water in the lower tissues. And then if it happens to be accompanied by some inflammation and the leg turns red, well, that's another sign, as you said, that something's going on.
Well, how's about if they say, well, you've got edema, which is swelling in your leg. And you say, okay, well, what are you going to do about it? Well, I'm going to give you this water pill, and it's going to make it go away. What causes edema in the first place? Excess?
It's retention of water in the lower part of your leg. That's what it is.
Yep.
Okay, now the question is why? And so one of the possibilities is, you're just accumulating water all over your body, and your foot happens to be lower in your body, and so when you're erected,
so you've taken on an excess, maybe too much salt. You're retaining liquid, and because you're erect, the liquid ends up going down the bottom of your body.
Right. Good. That's good. Now, suppose that happens in two legs. Okay. Then you think, well, maybe it's your heart, your kidneys, nutrition. The nutrition bothers you because you don't have enough proteins to keep up the pressure inside your veins to exchange well. But the kidneys, they may get sick and they're not excreting enough water, and so the water collects. And the heart, the pump may not be strong enough to pump the blood around, and it gets stuck down there. And so different problems occur from whichever organ is creating this retention of water. So you see that the answer to the question is what's going on can be very complex.
Sure. And I guess maybe there's a lot of people out there listening to the program, and I mean, I'm sure I was like that in previous times, and that is you shrug it off and you just keep going, and as a result of that, you're not able to do the things you want to do because it's uncomfortable. If your legs get swollen, you start hurting, you're obviously not going to keep going on what made them get that way. You're going to sit down or lie down or give up.
Okay, now suppose it's only one leg.
Yeah.
So now it's a different deal, because one leg is not that way.
Do you
so your heart doesn't work on one side?
Yeah, I was going to say, do you think that people that have swelling in one leg are probably a little bit more able or likely to recognize that they've got something that they got to go get looked at?
Could be. Could be, but I'm not so sure. Yeah, but in a way, yeah.
Yeah, because I think I would be. Now that, of course, I know a lot more about my body now than I did 5 or 8 years ago. That if I all of a sudden got swollen up, I'd know that, hey, that's...
You think it'd turn you on quicker.
I got to go get this.
Okay,
right
so let's take it. Yeah, maybe so. But then if you do, then the doctor that's looking at you has to think, oh, wait a minute, there's one good leg here, so all is not bad with your heart and kidneys and so forth and your nutrition. So let's look in that extremity to see if we can find something wrong. So
you begin, I guess, what would be the process of elimination. It's not this because you're okay, it's only one leg, and it's not that because you tested me, and it's, in other words, what do we do? What's that process to find out, okay, what's causing this leg to be swollen? What are we going to do about it? Yeah, so it's where that doctor says that, well, it doesn't. I don't need to check your heart and your kidneys and all that to find out what's wrong with one leg. I got to look in that leg and see, are the veins okay? Or do you have any injury in your leg? Do you have any infection in your leg? Is there something blocking you inside your abdomen?
So
Okay, now if that leg, that swollen leg, is accompanied by a sore or a laceration or something that's visible outside of just the swollenness, then would it even be more tempting to treat that and think that you treat that, the swelling's going to go away?
that's a really hot question because the inflammation around the sore may cause the swelling.
Mm-hmm.
But, the swelling is the body's reaction to an injury. So it's gathering its forces to bring blood supply and so forth to the part to try to heal it. On the other hand, edema in the tissues will prevent healing to a more or less extent and sometimes to a profound extent.
Is this because it damages circulation or that you don't have circulation in that area? Why is that?
Well, it probably is because the capillaries are not able to do their job very well, and so the transfer of nutritional elements and the removal of waste that the body does when the capillaries go through the tissue, that probably doesn't work well.
How would a swollen leg end up being something that could affect your heart? In other words, you said that if it's heart disease and you've got two swollen legs, maybe that's part of the heart disease that you got the two swollen legs. But if something starts in a leg, some sort of a trauma or event or something causes swelling, eventually it may affect your heart. You've said this before, and how is that?
Well, wait a minute. It's kind of the other way around, Mike. If there's something wrong with your heart, your leg may swell.
Okay.
If there's something wrong with your leg, it won't affect the heart that per se, unless you have maybe an infection that travels the heart or something. But no, it's the other way around. So if you got both legs out, then the doc's going to go look at your heart and see if you're retaining fluid for some reason. Okay. Mm-hmm.
Yep. Okay. So, but what we're trying to do here is track the one leg part of it. Now, is it sometimes the case where you get a patient that'll have a swollen leg, say the right leg, and you'll be treating that and it'll go away, and then all of a sudden the left one swells up from the same thing, not from a heart, but from whatever was going on in one leg? Can it be sort of transferred to the other leg, or are they independent?
Well, they are independent. Mm-hmm. No, it won't just transfer because there's some blockage in a vein in that, but the same disease process, for instance, either varicose veins or blood clots or even an infection might transfer from one leg to the other.
I remember once a while ago that we had a patient in with us during the program, and that this guy was in pretty good shape. He was young, strong, tough, and he had serious valve problems in one leg and perfect valves in the other leg. Mm-hmm. That must be quite an enigma, quite a hard thing to sometimes figure out, because one leg is no problem and the other leg's all jammed up.
That's right. But that's right. Mm-hmm. And that fellow had probably, as a very, very young, I know the story, and as a very, very young person, he began to have trouble with one leg and not the other. And when we looked at him, he didn't have valvular function in that leg.
I did notice one thing, that once he had tackled the problem and was able to realize that he had this anomaly going on, or this abnormality in one leg, that he was going to be able to monitor it, and that it needed to be monitored. And it seemed to me that he was doing exactly that. He realized that he had something that was going to recur, but as long as he kept on top of it, he could enjoy life. He didn't have to be a victim of it.
Yeah, well, all of us in practice for a long time have certain cases that are incredible, and he's one for me because I first saw him at age 16, I think.
That's amazing. 16.
Yeah, wow. And he's now in the mid-40s. And so I'm a very active person, but and he didn't have valves in one leg. But the other leg was fine. In other words,
he didn't have valves that weren't working. He didn't have them.
You know why he came in? He came in, his dad brought him in, and he said, my son's a pretty good athlete, and he's playing football pretty well. I'd like to encourage his activity, but he's got this swollen leg, Doc. Is it okay to play ball? And then we found out they didn't have valves in that leg. Well, so we followed him through his life. He's been a very active, successful guy, and he's on his feet in his work 8 or 10, 12 hours a day. During that time, he has slowly developed, in spite of doing everything we told him, he has slowly developed increasing changes of the veins and then of the skin over a rate now. So we followed him at least 30 years. And
Talk
during
about
that,
a great long case history to draw experience from. This guy is a quintessential example of, wow, here's something that you can deal with, but 30 years later, he still got it.
Yeah.
Yeah.
So how long it would have taken him to get into trouble without doing the things that were done, because we could see him, in his teenage, he was getting varicose veins that had to be treated. And then he used support all of his life, and he did all the things that he could do. And he's been able to stave it off, so he never got sores in his legs. But he's got brownish discoloration in the legs, and does have some swelling, and does have recurrent veins from time to time. So what we found out was that you can see that the progression of the problem occurs in spite of the things that we know to do, but we probably can slow it down significantly.
Okay, and that being said, and we love to see him again one of these days, because what was impressive to me about his attitude was that he, I don't want to say he embraced the condition, but he learned how to deal with it and did the things that he needed to do. For instance, let's talk a little bit about some of the things you can do right now if somebody's out there and has a swollen leg. Number one, we talk about elevation, but number two, if you have a constant swelling, do it like I do, and get a wrap or get a compression stocking, or get something that'll make you more likely to be able to go through your workday without having to stop because you can't, because your leg's sore.
Great advice. The most important thing I think you can do is get a diagnosis. So swollen legs are not the normal condition for a young person. So somebody with swollen legs in teenage or in their young adulthood, they deserve consultation. Try to find out why those legs are swelling. And then they go through all these diagnostic things we talked about. As time goes by, though, another point that you like to make is things add up, and so maybe your heart goes bad, or maybe you get chronic disease somewhere, or maybe you have an inflammation in some area, and things accentuate, and then you have more than one thing. That's a harder thing to handle from a medical standpoint.
Yeah, and I would think that we have these conflicting issues with the more conditions we have and the more medications we're taking. We talk about this a lot, that some things actually argue with another. We reeled off a number of conditions for swollen legs. Initially the varicose veins or obesity or the edema, the phlebitis, all of these kind of things that you talked about. And I think that almost all of us have some manifestation of one of those. It just stands to reason that as we get older, there's certain things that can happen. We got something going wrong. Right. And maybe today, because of the diagnostics that you do in your office and that vascular clinics do, is that some of these other things get pointed out by a vein doctor that isn't a vein condition, but needs to be addressed by someone else. You know what I'm getting at?
Yeah. And usually it goes the other way, though, because the general doctor seen him first. But your point is right. It can cut either way. And when the doc is looking at your veins, that doctor also has to be thinking, what about all these other possibilities? And so there's a lot of consultation that needs to go on between physicians.
You know how we are. We come up with this attitude of instant gratification. We want something right now. You give me, I'm sore. You're my doc. What's going wrong? Give me the pill. I got to go to a wedding. I got to leave. I got to leave town. It happens all the time. And I know that there is no magic pill, say, for instance, yet for varicose veins, but you do give some medications out. There are some medications.
Based on the diagnosis, there are a lot of, there's a whole realm of medications. And so, and also, the first thing, though, is to know, for the physician to know what he's treating.
The thing that fascinates me the most, and I think maybe that everybody listening can relate to this in some way. You often talk about the skin, the discoloration or the hardening or the leathery or the orange peel or anything else. This organ called the skin. Everybody can relate to that. That's something you can see pretty much, as long as you're not too big that you can't see, that you can see. Looks to me like certain of these skin conditions that come up as a result of some of these diseases are kind of permanent, and you only get one go around, you know. And once it happens, then you've got maybe something else to monitor besides a vein. You also got to be watching your skin all the time.
Yeah, the skin is a tremendous. It's a tremendous organ. You know, it covers our body, and it lasts for 100 years, no matter what we do to it. So that's pretty fantastic. And the skin has enormous properties to heal itself, as everybody knows who's ever scratched or cut themselves, and that's everybody. So this is one fantastic organ. But the point you made was once you get a bad enough injury and the skin is replaced by scar tissue, then it's not the same thing.
Yeah, let me ask you this, because we often deal with, when we talk about varicose veins and the treatment thereof, you've often differentiated between a vein and an artery. We know that the artery is bringing the blood down under pressure from the heart to your legs, and that the disease of diabetes is sometimes an arterial or artery disease. But you've also mentioned that sometimes the ability to heal, whether it's diabetes or whether it's edema or phlebitis or anything else, if your skin's all, had it, that's one less help you're going to get. In other words, the skin works to help you heal other conditions. Oh,
absolutely, yeah. No, well, when we have a wound, we think that when the skin heals, it's healed, and that's a common error, because that only means that the skin on top is closed. Underneath, you still may have some bad stuff going on. So,
I got to tell you something interesting. As a former type 2 diabetic, I guess I got to a point where I'd had discoloration and some leathery stuff on my legs, and obviously, I said goodbye with much aloha to diabetes a long time ago, type 2 diabetes. But the damage that had been done to the skin didn't go away. I mean, a lot of it went away, but it didn't completely go away. In other words,
what didn't go away?
The discoloration and the texture.
That's true. Yeah.
And that means that I probably shot my wad with regard. That's it. It's not going to come from the inside out. I'm not going to end up with nice supple skin because there was irreparable damage done. And I think a lot of people look at that and if they get a hold of getting treatment, they could avoid being in real trouble later with skin that doesn't work anymore.
Well, okay, yeah, that's right. We're into veins that have misbehaved, and you had ulcers, and that's with whatever complicating factors. So once that's replaced by scar tissue, and we see people whose whole ankle is a massive scar. They don't even have normal skin or normal tissues underneath. You call it the tissue just under the skin is a subcutaneous tissue. That can become all scar tissue. So as soon as I bump up against the side of the door, that superficial tissue may be injured, and then it exposes the scar underneath. The scar doesn't have good blood supply and has very little tendency to heal.
I'm thinking that in itself is a real condition that needs to be addressed by a lot of people, particularly as we get older, because we've often heard that you got to watch out for mom because mom's skin is very tender. Sometimes you can just touch an elderly person, and just touching them gets to a point where it damages the little skin that they have left.
That's a big one, and so as the population ages and their skin ages, then this envelope that covers us gets thinner, and the tissues that support it, call it supporting tissues, but the tissues in and around the layers of the skin and just what's underneath, they atrophy, they go away.
It's kind of interesting because I know this is slightly off topic, but I've got a dear friend that's been a charter boat captain for forever, and this guy's out in the sun 6 days a week, maybe 7 days a week. Yeah. And from early in the morning to late in the afternoon, cleaning the boat, working, talking, working on the boat, fishing and everything else. The guy's got skin like leather.
Oh, he does.
Oh, yeah. I mean, his whole body. And yet he's strong. He's a strong guy.
Yeah.
But now, every time he bangs it, just like he says, he actually walks around hurt all the time because his skin doesn't work. It's just not working anymore.
So it tears.
Old leather, tears open.
Yeah. Yeah, we call it, a lot of older people will have, I call it apple peel lesion, but anyway, they bump up against something and the layer of skin just peels back.
Mm-hmm.
And it's a very frequent thing. And
Yeah,
so
that happens to me. I mean, I've experienced it on my hands and arms a lot, to the point where you think, gee, how did I do that? Well, it doesn't take much. It used to take, I think, when I first got it, and when I was probably in my late 50s or early 60s, when I first bumped up against something, I go, ouch, and then it would bruise. Now I'm looking at bruise and say, I must have hit something. I don't remember it, but I must have hit something.
I hardly even feel it. Well, me too. And so, but there's a real trick for that, and people need to know. So if you wipe the skin back, then it gets kind of bloody there, and it's not something people want to look at. However, if you tease that skin back out so it lays back right in its bed, and keep it there with even just a piece of tape holding it there, it'll heal.
Isn't that funny?
Yeah,
most people want to take it right off. Oop, the damage, throw it away.
No, and so right, and or if you don't do it, the skin is elastic, so it'll kind of contract to one side. But if you tease it out and stick it there and leave it for about 10 days or 2 weeks, you take the bandage off and it's healed.
Can sometimes,
whereas if you didn't do that, you have a big sore.
Yeah, I was going to say usually the sore is the after product of this, but I would imagine that sometimes like I will get like little bruising, but I know that some people get actual tears where a big
they do.
It's like a slab,
right?
And I would imagine the thinner you are, or the thinner the skin is, the more likely that thing is to go deeper. I mean, it could be in other words, it could be a real trauma.
Absolutely, and in treating people with swelling, if you treat a very senile, a very much older person who has thinned skin, and the treatment for swelling is put pressure on. Well, if you put too much pressure on sick skin,
I'd imagine you're going to damage that skin a little bit. Huh?
Yeah, you make a new ulcer. And so, talking just in numbers, though, a normal amount, a big, strong guy like you could probably handle 40, 50, 60 millimeters of mercury of pressure. I mean, a lot of pressure.
That's a pretty good squeeze.
That's a good squeeze. But an old person with very delicate skin and the 80 or 90 pound person who's nothing but skin and bones, that person may not be able to tolerate more than 7 millimeters of mercury.
Well, let's talk about that for a minute, because a lot of these folks are folks that are maybe on their bucket list is to go back to their old hometown once more, or to visit, to go to Europe. They've never gone to Europe. They finally got some money and some time, and they can go to Europe, and these are the people that are the most likely to suffer as a result of that condition as they travel, because they're just getting frail. It's a fine balance, isn't it? You really need to be thinking about being pretty healthy before you decide to get on an airplane.
Yeah. Well,
I know that came out of nowhere, but I mean that it just so happens that in certain places.
You mean lots of things can happen to you on the trip?
Sure,
that's true. On the other hand, the other thing about that is don't get on with a sore leg. We talked about
Well,
that.
see, you mentioned pressure, so I'm thinking every time I travel, I make darn sure that I have my stockings on. But because you say I'm a big guy, I can take that pressure, that means that a person that is frailer that is going to do that, they cannot use the same kind of pressure on their stocking. They have to use a much, but some is better than nothing. You better do something.
Yeah, and a little bit is better than nothing. That's for sure. Yeah. But a little bit and a little bit of pressure in a man like you isn't going to do a damn thing. Mm-hmm. I mean, it just can't touch you.
Okay, let's get the big 800-pound gorilla in the corner here. There are a lot of things that we've talked about that have to do with pressure, with swelling. We've mentioned obesity. We've mentioned diabetes, phlebitis. We've mentioned dermatitis. Some of these other things, a lot of which happen to people that are larger than normal, are big people. And I guess as a physician, it must be a really, really tough thing to really have to explain to something, look, you have a lot of conditions here. I'm treating you for one of them. You're going over here for another one. At the core of this is that you have too much weight on your body to be able to enjoy a normal life. That's why you got some of these conditions.
That's a tough one.
Yeah, tough one, isn't it?
Yeah, and so that was really the reason that I wanted to bring it up here, because that is very rampant. You see a lot of that, and people really do not understand it. And as a matter of fact, physicians who don't see a lot of it might not be too familiar with what's going on, because basically there's a term called cellulitis, and that's a common term, but what it means is cells are inflamed, itis, and so it's inflammation of the cells. Well, what's the first thing to do? Put a person on antibiotics? No. No, that's not really it, because if there's a lot of edema in the leg, the edema itself will cause this. And so it's almost like a congestion.
An antibiotic is not likely to address edema.
There's no bacterial problem.
Yeah.
And so antibiotics only treat the bacteria. Yeah. So, but, the general public wouldn't particularly know that. They know if you got a sore, well, then often antibiotics are necessary because there are bacteria there. But where they're not bacteria, they're not necessary. But what is necessary is to get rid of the swelling. And so that takes a different approach, where people elevate their legs, they put some kind of compression on. Maybe they take a diuretic if they have some kidney problem, or just to get rid of fluid. But the real thing, without which it will not heal, is compression and getting rid of the edema. So it's a big lesson, and it's a lesson that I can't tell you how many people would benefit from knowing.
Almost everybody realizes when they go through a weight loss program of whatever kind it is, as you start losing weight, you wake up about other things, like energy. Like you find yourself wanting to do things that you've been maybe procrastinating or putting off because make you too tired. You get out in the yard and you start raking, you get dizzy. Well, that's no fun. I'm not going to rake. Okay. So pretty soon you have 10 million leaves in the yard. You better rake, you're going to have a fire. So I'm thinking that sometimes people have to actually have a fire on their body, because they need that. And I know that a lot of times when you get referred somebody, that they are working on with their doctor, their regular doctor, on weight loss, but they've done damage. Can a patient see from the treatment that they're getting better because they're getting treatment and because they're losing weight, because they're managing their weight better?
Well, I think so. I mean, I think you're a prime example that you went through that. On the other hand, there are a lot of people who can't see that. They're not going to look there. You only see what you're looking for. And so if you're looking for loss of weight as being something good and you don't consider it something good, you're not going to see it.
Yeah.
Well, that's denial. We call it denial, right?
There's this really great thing out now, and they're pushing it in weight loss clinics and in weight programs and in gyms, and it's 40 at 40. For the number 40 at 40 means if you're 40 years of age and you have a 40-inch waist or under, you're okay. But I remember that a guy with a 40-inch waist used to be called fat. And now they're saying, well, it's okay to have a 40. In other words, maybe you shouldn't have a 40. Maybe you should have a 34. But if you're a 48 and looking at a 34, that's just not going to happen. In other words, there are some of these magic plateaus that if you cross over this bridge,
those are guides. Yeah,
you're a train wreck. You're looking to get derailed.
So that's an easy gauge. So if you're 80, is it okay to have an 80?
Yeah, I think that it starts peeling off. For instance, there's this tremendous effort now, as you know, and there's programs all over the place, including one that I do, on testosterone replacement for men. They get to a point where you're just not producing testosterone like you used to. And, women have menopause, and they need hormones, and men have this testosterone decreasing. And they look at that at being the panacea. But if you don't address other concern, it doesn't matter how much you take, right? Because your body just is, I guess, going through this gradual shutdown where it's just rejecting the good things in life because you just don't have the energy or the condition to enjoy them.
Well, absolutely. What that gets down to is the diagnosis again. And so some of the things that, like the 40-40, well, that's subject to medical judgment too.
See, if a guy out there is listening right now, Doc, is just 44, is he doomed? No, he can. No. Some guy can. If you're 6'8", you can be a 44 probably.
That's right.
But if you're talking just about regular folks, there are some gauges out there. As is, and this is where I wanted to swing this around to. There's a chart that you all doctors use that say if you're so many years of age and you're so tall and you have a body mass index of this is how much you should weigh. And if you weigh over that, you're kidding yourself, really.
And some of that's subject to some discussion too, because there are different body types. And,
sure.
There are people, but no, those are good guides. But the guide I really want to go back to is people take a look at their legs, and if they're having some problem there, it's time to find out exactly what's going on.
That's precisely, folks, why we've called this program since its inception Healthy Veins, Healthy Legs, because there are a lot of things that can go wrong with your legs that aren't necessarily your veins. But if your veins go bad, your legs are going to be bad. And this is a primary concern of us here on the program.
Well, no, and it's also one of the stages of venous insufficiency.
Mm-hmm.
So, we've talked, there are various stages where the veins are better or worse, causing problems, and they begin with little varicose veins, and then they progress through skin changes. But one of those areas is swelling and beginning of discoloration of your leg. So when you begin to see that and you have a vein problem, you've really moved off from just a simple problem to something more serious that does demand attention, or it's going to get worse.
Let me ask you this, Doc, because I know this. I think I know the answer, but I'm not sure. One of the greatest diagnostic tools that has come along for a long time in any specialty is the ultrasound treatment, the ultrasound that you use, the sonic stuff to determine. Does it tell you other things too when you're examining somebody's legs? Does it help in the diagnosis of other conditions as well as vein disease?
You can, because you can see various normal or abnormal findings in all the tissue planes, maybe in the muscles or maybe in the tissue under the skin. It's not as precise. It doesn't have labels on it, but it does have identification where you can say this is not normal and we need to maybe do an MRI or something to see what the soft tissue change is.
Okay.
That could be a cyst, or it could be an abscess or something.
Yeah, because I have noticed that when I've had this treatment, which I think is, as a patient, it's fascinating to be able to see something that's inside your body going on with this probe that's outside your body. I mean, it doesn't even hurt. It's just this little cold metal ball that's running up and down your leg and throwing this echo and this sound in your leg that comes back and gives you gives you the doctor a live and in color look inside my leg. It's amazing.
Yeah, and it's so useful that all the emergency rooms now, or many of them, have ultrasound, and they have somebody. Well, some people are better at looking at them than others, but person that has some familiarity with it can make a lot of diagnoses.
You know what? Here's an interesting angle. Because if that's the case, and if this equipment is now in more and more ERs than before, I would imagine that just a cursory examination of somebody that's in there for some trauma might reveal to a operator of the equipment that knows what they're doing, boy, this person's got some, on top of everything else, they got some really bad veins here.
Oh, you can, veins and a lot of other things. So, for instance, an emergency room will often have ultrasound, and they can look immediately and see whether your aorta blew out. Yeah. Something really big deal with the vascular system and with other systems. They can, you can see lumps and bumps all over the place. You can see knee fusions. You can see knee cysts, and you've ever heard of Baker's cyst, and that's a big dilation of the knee. And they're all over the place, and they're one of the causes of acute pain in the leg. So yeah, it's very useful for soft tissue.
I asked something earlier, and if we combine it with two-part question, one is about antibiotics, and the other is about diuretics or water retention pills. You've talked that there is abuse of them. Antibiotics. If you grab antibiotics for every little thing that goes wrong, what are some of the complications, or what are some of the problems that you might get from too much antibiotics? Yeah,
that's a really good point, and they're serious. Mm-hmm. They range from you may be allergic to it.
Mm-hmm. I've noticed that, Doc, that a lot of times in your office, are you allergic to anything? Once you're a regular patient, you know the answer to that, but that's one of the first things that's got to come out, particularly antibiotics.
Okay, and so everybody fears being allergic to penicillin. Remember all of that? And so
Sure.
when you're 2 years old, somebody said, well, maybe you're allergic to penicillin. That follows you till you're 80. So there's some question about that. However, there's a lot of allergies to antibiotics, and so they're duly recorded and carefully recorded. But that's only one. Use of the antibiotic when it's not necessary may encourage organisms in the body to become resistant to it, so that over time that antibiotic becomes less and less useful in the population.
Is that sometimes why a doctor will move you from one antibiotic to another? Because we mentioned before that when somebody comes in with a leg ulcer, if they're getting treated as though it were an external injury, that they keep putting one antibiotic on it after another, and none of them work, because that's not the issue.
So what's going on, what should be going on, is that the physician is taking a swab or a piece of tissue and then incubating that in a growth medium to see what specific organism is growing. And then once you have that organism, then you can expose that organism to all different antibiotics and see which one is effective on it. And this happens within, you can take a swab now, and in 48 hours we have all the sensitivities, and we can say, oh no, you use antibiotic A, but don't use C. And then you have to look and see, well, are you allergic to antibiotic A? Or,
sure.
And so there's a lot to it. And you can be taking an antibiotic and be appropriate for the organism, and over time, the flora, we call it the flora, but the bacteria in the wound changes. And from one that was sensitive to the bacteria to one that's resistant to it, or a new bacteria comes up that requires a different antibiotic. So it's a dynamic problem that has to be.
That must be why there's so many different antibiotics, because none of them are the catch-all. I mean, it was simple. Back when I was a kid, there was one medicine called aspirin. You took aspirin, that was it. Or you put on some cream, and that was it.
Well, that's right. Well,
now it's really confusing.
Well, aspirin's held up very well, but
I should say.
But the antibiotics are really a specific treatment for a specific problem, and so frequently used as just an umbrella kind of thing. Well, that looks inflamed, so here's an antibiotic. That is not proper medicine, and it's so often demanded by the patient. Patients constantly come in and say, well, I want an antibiotic. Well, give me an antibiotic cream. I want to put one of these creams on my sore because it'll make it well. Well, I can tell you in the wound care clinics, you see many, many people who all you have to do is take those creams away from them, and they get over the allergic reaction that they're suffering, and their ulcers heal up. I mean, this is called dermatitis.
Yeah,
it's one of the biggest things of all.
Well, we try to cover the gamut here on the program, and that is a big red flag should go up over the overuse of antibiotics or diuretics, because you can use one thing to take care of a problem and create another problem by using the one thing that took care of the other problem. So I mean, don't self-diagnose whenever possible. So
we're getting toward the end, but the message is that redness and swelling and that sort of thing is subject to accurate diagnosis and accurate treatment. And in our urban society, where we have access to people who can do these things, that's really the standard that should be followed.
Yeah, and I'm thinking that that's the way we want to end up today, to make sure that when you have, and particularly, I guess, the real klaxon alarm should go off when it's just one leg. When you have one swollen leg, that's the big sign that you've got an issue that needs pretty much rapid attention, because that's why it's swollen.
Right. On the other hand, it's also, if both legs are bad, you better start looking at the organs in the body.
There you go, friends. Okay. And so, I mean, we want to leave you always with a positive note. The good news is there is good news. You can go ahead and get a lot of these things treated and a lot of these things dealt with. And as we go into future programs, we'll get more specific. But today, you've learned a little bit about varicose veins, obesity, phlebitis, dermatitis, all of these things that can create a swelling in your leg. So the quicker you get one looked at after you recognize that you have some, the quicker you're going to get back to whatever it is that you're trying to do. So that being in mind, thanks so much for being a part of our program today. We'll be back in next time. In the meantime, if you want to know a little bit more about what's going on, go to the KistnerVeinClinic.com, www.KistnerVeinClinic.com. And make sure that you understand that these healthy veins, healthy legs we talk about, it's a reality. It's not just the title of a show, because if you do have healthy veins, you will have healthy legs. We ask you to come back and see us again next time. Once again, thanks for listening. For Dr. Bob Kistner and all the hard workers at the Kistner Vein Clinic, I'm your host, Mike Buck. We'll see you next time for Healthy Veins, Healthy Legs.
Thanks for listening to our program today. And for more valuable Healthy Veins, Healthy Legs information, visit us online at www.kistnerveinclinic.com.